Right, good morning. I would like to welcome everyone who is present in the Council chamber and all those watching online to this meeting of the Lincolnshire Health Scrutiny Committee. For those of us in the chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the Council chamber through the rear doors, through reception and assemble in the car park at the front of the building and await further instructions. I would also request all members to place their phone on silent, and to ensure everyone has the opportunity to ask a question, please ask a maximum of 2 questions per item and to keep these succinct and concise. I would like to remind you all that your comments will remain accessible online. I'd now like to move into agenda item 1, apologies for absence and replacement members. Jess.
Thank you, Chairman. We've received apologies from Councillor Rob Kendrick, who's being replaced by Councillor Noisia. We've received apologies from Councillor Lucille Higgs, who's replaced by Jonathan Pessel. And we've also received apologies from our Health Wash colleagues. Thank you.
Thank you, Jess, and welcome Councillor Sear and Councillor Pessel to this meeting. We'll now move into agenda item 2, declarations of members' interest. This is an opportunity for members of the committee to declare any pecuniary or other interests. Do members have any interest to declare at this point? No, thank you. Should one come up within the meeting, just make us aware at the time. Thank you. I'll now move into agenda item 3, the minutes. This is to confirm the minutes held on the 11th of September 2024 as a correct record. They are found on pages 3 to 15 of the agenda pack, and as the committee has had the opportunity to read these in advance, I plan on taking these en bloc. Do I have a proposer for those, please? Councillor Smith, and seconded Councillor Morgan. All those in favour, please show. Any abstentions? Thank you. Any against? No, thank you, they're carried. We'll now move on to agenda item 4, the Chairman's announcements. My announcements were circulated as part of the agenda. My supplementary announcements were circulated via email on the 8th of October. Just like last month, these announcements are substantial, so I would ask for only brief questions or statements. I would like to draw your attention to my proposal in bold type on page 19, which is to record the committee's congratulations to United Lincolnshire's Teaching Hospital NHS Trust on achieving teaching hospital status. We look forward to the benefits of this for both patients using the trust as well as the staff there. Does anyone have any questions? Councillor Smith first, please.
Thank you, Chairman. With respect to the reply you have received with respect to Section 106 on behalf of the Right Honourable Wes Streeting, that reply is very positive. However, I would just urge that he and his ministers in the department make sure they are linked up with the Department for Local Communities, because the review of the National Planning Policy Framework consultation is basically counter to what he is saying. It basically says, long and short of it, Chairman, is houses will be built wherever and whenever we can fit them, irrelevant of the consequences. So whilst I know his reply is very positive, I would just gently urge that if there's something we can do to just gently suggest in that direction that we do so. Secondly, Chairman, I just want to draw members' attention to the last paragraph on Section 8 in your announcement. The fact that weight are causing deaths of 14,000 people per year is staggering. If you take the size of the British Armed Forces today, which is approximately 82,500 men and women, of this council term, we have lost half the size of the British Armed Forces in totally avoidable circumstances. That is simply unacceptable. Now, Chairman, if you imagine, as we saw in Afghanistan, those numbers coming back in coffins draped in the Union flag, you would have the public, quite rightly, on the streets in every city, every town, demanding action and change. Business as usual, Chairman, in this regard, simply is not good enough and is not an option. And if there's anything we can do to put pressure in the right place, I think we should, Chairman, because I knew there would be some figures like that, Chairman, but certainly not that figure. The 40 to over half the size of the British Army in 3 years, that is staggering. That is verging on the levels you're seeing in Ukraine in a month we're seeing in 3 years, which for totally avoidable reasons is just staggering. And with your indulgence, Chairman, I would like to make one brief point, which is on the enhanced use of digital. In my experience, Chairman, this is being forced because, and I'll give you a personal example, I can't get Granted, different health authority, but I'll use the example. I can't get letters sent to me in a timely manner from Nottingham for appointments, so now I have to have them sent to my mobile, because if I don't, I'll miss the appointment. And then they'll say, oh, you missed, you're off the caseload, you're off his caseload, you need to be re-referred. We need to make sure that is a choice, and it's not a forced choice, it's a genuine choice, because there are a lot of residents who, A, aren't technology friendly, or B, much like myself, I know how technology works, I have privacy concerns with how it works, and I would much rather not have to do it, but I have to. So I just, if there's again anything we can do, just to remind colleagues that this has to be a genuine choice and not a, we're leading you down a dark alley with one hand tied behind her back, I'd be very grateful, and thank you for indulgence, Chairman.
Thank you, Councillor Smith. I think we do say on a regular occasion, whatever item we do, that online only is not the way to go forward, especially with an older population and so on. So I think we do loudly get that message across, and nationally, of course, we will try and feed back as further information comes along. But of course, we'll remain locally pushing as much as we can to get those points over. Thank you, Councillor Smith. Councillor Allen.
Thank you, Chairman. It's to do with the information that's been provided in section 1 about cancer and cancer treatment. And the question I've got, and I don't know whether you know the answer, and it's not entirely clear from the information that's been provided, but it does seem as though we've got 6,865 diagnoses in Lincolnshire, but only 5,352 treatments taking place, which is a disparity of about, I don't know, 20% or something like that. Does that mean that it's too late for those patients, or is there something else happening?
Simon, I don't know if you can answer that. I think from what I can gather, that information is not forthcoming that's within that paper particularly, but we can always ask the question going back. But yeah, we'll ask that question and come back to you, in which case, Councillor Allen.
Well, thank you, Chairman, but it's like dragging, to a certain extent, we get information, we raise questions, we get more information, we raise questions. Why can't it just be clear in terms of what it is that's happening? And the second point I would make, I would support your comments in bold regarding the teaching hospital status, which is very good news.
Thank you, Councillor Allen. Normally when we ask the questions about, there's always a reason as to why, and often it doesn't make sense. So, but we'll still ask the question and come back to you. Councillor Mackinson-Saunders.
Thank you, Mr. Chairman. I do get frustrated that Health Watch only seems to do things in South Lincolnshire. I can't remember when they actually had a meeting in East Lindsey, for instance. They used to have quite an active group in Louth. That's disappeared. I don't know, you can blame COVID for everything, but it had gone before that. And trying for somebody in East Lindsey to get down to Jakeman's Stadium, which is jolly nice, but, but everything seems centred on South Lincolnshire, and I do think that's an oversight. I think in a county as big as Lincolnshire, things need to move around slightly better because we all have our concerns. And on page 31, Lord Darcy's report, patient engagement, the patient voice is not loud enough, and I can't underline that enough times. And it's really important. And unfortunately, people are frightened of complaining about services, because if you complain about your GP, you might find that you're having to look for another GP, etc., etc. And if there's anything that we can do from here to make that better, I'd be grateful.
Yeah, thank you, Councillor Mackinson-Saunders. It's a shame that we haven't got a Health Watch colleague here today to respond to that, but I'm sure we can pick that up anyway and just sort of feed that in. And in terms of that, I think the other side of that as well is people just feel like when they do raise issues, it doesn't go anywhere, so they're wasting their time. And that's something I think we need to get over. And, I think it is getting better and they are listening more, but there's been years where they certainly didn't seem to take much notice. So that's the big problem we seem to have. Councillor Cleaver.
Yes, thank you. I'd just like to echo the sentiment about Health Watch events. I wouldn't say the South Lincolnshire, I'd actually say South East Lincolnshire, because we don't seem to have any events ever put on in South Kesteven that I'm aware of. I certainly get everything that Health Watch sends out, and find myself unable to publicise them to my local constituents because there's never anything within easy driving distance of SK. So, yeah, I echo what you say.
Okay, thank you, Councillor Cleaver. I've got Councillor Morgan next, please.
Yes, thank you. Yeah, first of all, on health. Oh, sorry. Yeah, thank you. First of all, on Health Watch, one of the things I was really quite surprised at is that the body has the ability to vote at board meetings, and they opted not to. And I find that quite staggering, given they're one of the only patient representative voices on the board, ULHT and other boards. Why on earth would they not do that? I would also echo the comments that you just made, that having attended a number of board meetings, I was, shall I say, being polite, hugely disappointed at the actual lack of input from Health Watch representatives. I felt very much that rather than representing patients and our concerns, what they were actually doing was, in effect, trying to pacify those that they were working with instead. I'm not sure what the reason is for that. Maybe they felt they might get listened to more if that was the case ultimately. But it definitely didn't feel like they were our voice and our representatives certainly when we were fighting for Grantham Hospital, A&E. I'd like to also pick up the point about the response from the Secretary of State for Health regarding Section 106 funding for healthcare facilities. I think that's very misleading. As a chair of planning, and in fact we picked this up in our own committee, and I'm seeking subsequent follow-up to it. There are only certain aspects of NHS provision that come under Section 106. It's mainly GP provision. So as our areas grow, we aren't actually seeing the growth reflected in the provision of accident emergency, acute care, or our hospitals. And a number of NHS beds in our local hospitals. So that needs addressing. There is a big issue there. Thank you.
Yeah, that's exactly what we did raise within the letter anyway. So when it's been fed back, that's one of the issues that they've sort of said they will look in and cover moving forward. So thank you. Will you switch your microphone off? Thank you, Councillor Morgan. Any other comments on my announcements? No, in which case, do I have a proposer that we note them? Thank you. And also that the committee's congratulations to United Lincolnshire Hospitals Teaching Trust be recorded on its substantial achievement in being awarded teaching hospital status and the benefits that the status will bring to the patients using the trust service, as well as staff working within the trust, be welcome. Do I have a seconder for that? Thank you. All those in favour, please show. Thank you. That's supported unanimously. In which case, I'll now move on to agenda item 5, suicide prevention in Lincolnshire. This item was circulated as part of the agenda pack on pages 37 to 103, and for the benefit of the newer members of the committee, during 2022 and early 2023, the committee established a reducing suicide and mental health working group. This working group recognised the importance of providing more support to individuals who had attempted suicide and their families. This is one of the 8 commitments in the new strategy, and I'd like to welcome our presenter, Lucy Gavins, consultant in public health. If you can take us through the presentation, about 10-15 minutes, and questions at the end, please. Thank you, Lucy.
Thank you, Chairman. So yes, this morning I'm going to share an update on our suicide prevention work in Lincolnshire. I will start with telling you a little bit about the local picture and what we know is happening in terms of who is sadly dying by suicide. That a lot of that information informs the work that we do locally to think about preventing future deaths. And then I'll also share some of the work that we're prioritising under our current Lincolnshire suicide prevention strategy. There's no single reason why people die by suicide. Every single death is a tragedy, and a suicide death is often the result of kind of the ultimate loss of hope, perhaps feeling trapped, loss of purpose in life. There is a well-established relationship between suicide and mental ill health, but many suicides happen impulsively in moments of crisis, with a breakdown for the individual and the inability kind of to deal with life stresses in that particular moment. And often those stresses are not necessarily linked to mental health, but are more closely linked to things like financial problems, relationship breakdown, chronic pain, illness. So there are lots of different factors that we see that lead to deaths by suicide in Lincolnshire. 2023 is the year for which we've got our most recent data. In that year, we had 105 registered deaths due to suicide or injury of undetermined intent in Lincolnshire. So just occasionally there might be suspicion that something was a suicide, but that it's not we've not got hard and fast evidence, so it would be recorded as injury of undetermined intent. And it's important that we look at all of those deaths so that we don't miss anything. So 105 deaths in Lincolnshire, that's a rate of 14 per 100,000 population. That is significantly higher than the England and Wales average, which is 11.4. Lincolnshire has consistently been slightly higher than the England and Wales average for the last kind of 5, 6, 7 years. And that figure of 105 deaths is an 8% increase on our deaths in 2022. Notwithstanding that every single death is a tragedy, when we look at our data across Lincolnshire, overall, because there's quite a small number across the size of a county like Lincolnshire, what we tend to do is look at 3-year rolling averages so that we can look for trends over time in a slightly larger group of people. And that allows us to look at patterns by geography, perhaps by socioeconomic status and other factors. And so the latest 3-year rolling average for which we have deaths available, there were 281 in Lincolnshire. And that's slightly higher than the previous 3-year rolling average where it was 265. We do see that our suicide rate varies by district. So Lincoln continues to be the highest district by rate in Lincolnshire. The rate's currently 20.1 per 100,000. Lincoln is consistently, for the last 3 years, has been in sort of the top 10 of all local authorities in the country. So this is a real priority area for us in Lincoln City. However, we do also see that we've got rates higher than the national average in Boston, East Lindsey, North Kesteven and South Holland. So it's not just Lincoln. This is really important work that we do across the whole county. And so in our response to suicide prevention, whilst we work closely with City of Lincoln, we make sure that our work, wherever it's possible, is county-wide. We do see fluctuation year on year between the districts as well. Within Lincolnshire, we see the highest number of deaths in middle-aged men and women. So that middle-age period, kind of 30 to 50, is the highest risk area, if you like, in terms of age. And around about 3/4 of suicide deaths are in men. And that mirrors the national pattern as well, kind of middle-aged and more in men. But there are some well-known priority groups for suicide prevention, for focusing our suicide prevention efforts. So, for example, as I say, middle-aged men, people in contact with mental health services, and also the criminal justice system are all at increased risk of dying by suicide, and also autistic people, and that's emerged over the last kind of 3 or 4 years as a really important risk factor both nationally, and it's something we're looking at locally as well. We also know, we hear a lot about certain risk factors that come up a number of times in the context of suicide deaths. So these are things like financial difficulty, economic adversity, alcohol and drug misuse, social isolation and loneliness, domestic abuse. So there are also those factors that we look at and we work closely with, for example, the Domestic Abuse Partnership in our efforts to reduce suicide locally. And just finally, in terms of how we understand what's going on locally for people, we work closely with the Coroner's Office as well to do deep dives into the circumstances surrounding people's deaths. And that helps us to understand risk factors, what was going on for them in their lives, and also any contact they'd had with organisations, services or professionals prior to death, so that we can work together to make sure that we're increasing, for example, training around suicide prevention, raising awareness of how to have conversations and how we can support people. And that helps to provide a richer local picture of what's going on. A lot of the work that we do at the moment to inform our actions is driven by understanding people who've died. One of the key things that we're now pivoting to start to do is understand and try and think about how we can better understand what's helped for people who have perhaps made a suicide attempt and survived and recovered, so that we can start to also learn from from people who are still with us, because by working with them to understand what's helped, hopefully that will also help us to enhance support. In terms of what we're doing then to prevent suicide locally, our suicide prevention strategy, as is in the report, has 8 evidence-based commitments. The first one, and this is one that we've embedded actually right from including in the development of the strategy, is about working with people with lived experience of attempted suicide or suicide within all areas of our work. So our strategy was co-produced with a number of people with different kinds of lived experience of attempted suicide and suicide. And we now, whenever we do any new work, we always make sure that we collaborate with people with lived experience, and that goes right from our strategic group that sits across the county, where we've got members who've got lived experience, right through to small individual projects, so that we can make sure that everything is co-produced. Another one of our key areas of focus is encouraging open conversations to help us reduce the stigma and raise awareness of the support that's available, and also for all of us to be aware of how to have conversations around suicide. One of the challenges is that if we think back to some of those risk factors, they're really common with middle-aged men. So it's very difficult to develop specific interventions, and we don't have evidence-based interventions that we can kind of specifically commission to support such a big population group. What's really important in this space is that everybody feels comfortable and confident and knows how to just ask a question, because one of the things that evidence does tell us is if you're worried about someone, asking if they're feeling okay, and perhaps probing a little bit further, and if you're really worried about them, asking, you know, do you ever think about suicide, can be a really important way to connect people to help. There was often in the past a myth around the thinking that would put the idea in someone's head, but that's been dispelled, and we know that that's now a really important question to ask if you're worried about someone. So there is training available, freely available to everybody in the county, that I'll talk a little bit more about later. A few other key areas within our commitments. So reviewing those recognised risk factors and making sure that we collaborate with other groups across the county who are working in that space, so around drug and alcohol related harm, domestic abuse. We work closely with colleagues in children's services and children's mental health services around kind of understanding and supporting children and young people at risk of suicide. So that's an ongoing piece of work. We work closely with the Rural Support Network to support our agricultural and horticultural community. We connect up with the military to understand how we can better support veterans. So there's lots of work ongoing to work with different communities who we know might be at increased risk locally. We make sure that everything we do is underpinned by evidence, and there is a growing evidence base consistently in this space, because over time we've learnt more and more about how we can support people who may be suicidal. And there's also a real focus in this for us on health inequalities. We do know that people who live in our most deprived communities are almost 3 times more likely to die by suicide. We have a focused subgroup that looks at support for children and young people. We often find that whilst in adults, we have a number of suicide deaths each year where someone isn't in contact with mental health services, and actually it's often social and economic factors that might underpin their distress. For children, we find that actually normally there is a role for CAMHS, and so we work much more closely with children's services and CAMHS and children and adolescent mental health services around child suicide. But it is important to say we do have very few suicides or suspected suicides in under 18s in Lincolnshire. We did have we had a bit of a rise in 2022, kind of in that period directly after the pandemic, but we have usually 1 a year, sometimes 2. So it is low numbers, but 1 is too many. And that is a principle that we do hold to. Just the final couple of commitments then. So really important for us, and this is a priority right from the start of the new strategy, improving support for people who have attempted suicide and their friends and family. There are a couple of projects that we have underway at the moment to explore how we can better support in this area, which I'll come on to mention. And then just finally, ensuring that all key organisations that have a role in suicide prevention and postvention, so support after someone's died, provide support for their own staff and colleagues. We have many, many thousands of people in Lincolnshire who are employed by large organisations that will come across people who may be feeling suicidal, or who may have come across people who or may have known people who've died by suicide. And there are good there's good evidence-based toolkits around for how we can support our own staff to make sure that we look after their health and well-being when they're protecting and helping other people. And for me, that also then builds that kind of community and that understanding across our society around suicide prevention and what we can all do. So just then to be specific about a couple of our priority actions at the moment, we did have our first system-wide suicide prevention conference in Lincolnshire last month. We had over 150 delegates from 30 organisations in Lincolnshire who came together with the aim of learning about what they can do to support suicide prevention and take that learning back into their organisations and into their communities. Really important for over this next kind of year will be promoting our new suicide prevention website that launched last month as well. That's a system-wide co-produced effort to create a source of information on suicide support available in Lincolnshire and how somewhere for people to go if they're in crisis themselves, if they're worried about someone else, to know where there's support available for them. The Recovery College is co-producing 2 courses for people who've been affected by attempted suicide, one for individuals themselves that will be being piloted starting next month, and another one for friends and family to support, so that we can support friends and family to think about and understand how they can best support a loved one who themselves has attempted suicide or is got suicidal plans. Then also recognising that important role of making a previous attempt, we're also continuing to explore what the evidence base tells us and what other areas are doing around supporting people who are actively suicidal or who've made a suicide attempt, but where they're not currently experiencing what we'd call a mental health crisis. So where it's very much driven by factors in their personal life, it might be social or economic factors, and making sure that we have the right support in place for those individuals to help them through that point of kind of suicide crisis. So that's everything from my perspective. I wanted to just share an update on work that we've been doing. There is a lot more detail in the report. And also, if I may, just to make a request that if people haven't undertaken the Zero Suicide Alliance training, it's 20 minutes, it's free, it's online. I'd really recommend it. It's got powerful stories in it. If you're able to do the training and also share it widely with colleagues, constituents, it would really help us to spread that message. So thank you.
Thank you, Lucy. I've got Councillor Smith first, please.
Thank you, Chairman. I was reading this, and it's very difficult to read because, on the one hand, the report says we're doing all these things, but the stats say a very different story. In my division alone, Chairman, I am aware, and I know of first hand, within this year alone, one tragically did take her own life, and the other we managed to prevent. He was as young as 10. So that's nearly 2 in 1 year already, and that's just the ones I know of in my division. I'm sure members have others. The simple fact is, Chairman, whatever we're doing, be it here, be it NHS, clearly, as the stats show, it isn't working. Because most of them, the ones I'm aware of, they were known to services, they were then discharged, and then it happened. And that is, I hear this, whether it's here, whether it's anywhere else in the country, it happens all the time, and it's becoming so common now that, oh, well, they didn't show any signs or any symptoms. People are very good at hiding how they really feel, because actually when you're that low, you do that as a defence mechanism, so you don't show any signs, because you're not going to have a big neon sign above your head saying I'm going to go and do something, because you don't want your family or your friends to worry. And Lucy is right, it often is, shall I say, external factors, be it bullying, be it finance, be it social, whatever, but we're not recognising the signs, and especially in men. The reason most men take their own lives in private is because they don't want to be a burden. That's why it's done in the way it's done. But also, Chairman, there are a lot of people who I've spoken to and who simply say, well, actually, the way the services are set up, they are not set up to help me as a man, as a male, to unburden or to explain my situation in a manner and get the help in a manner that works. They're set up in a way that seems to be counterintuitive to, not all, but to a fairly sizable proportion of men. And often, again, with societal, shall I say, what used to be societal norms, a lot of men simply won't seek help because they don't wish to be a burden, they don't wish to embarrass themselves, whatever the case may be. I don't know what the solution is, Shem, but business as usual isn't working, and there are too many instances where people are known to services and they're falling through the cracks. And if anything, Chairman, in the last 3 years, and especially since we did our deep dive into this, that doesn't seem to be getting any better. That seems to be getting worse. And I don't know what the solution is, Chairman, but something needs to change, because it's all well and good having a paper like this, but when the reality on the ground is suicides are increasing and younger people are attempting to or have taken their own lives, and more men are dying at the age of 30 by suicide, something's not working and something needs to change.
Yes, I will say that every year, so we have we get the updated data from the ONS every August, September time, and it has gone up. It has gone up year on year. When we look at our statistical neighbours, and when I look at the 20 local authorities with the highest rates of suicide across the country, they are by and large very large rural counties, often with a significant coastline. And I do think that there is a lot of systemic challenge that we have in counties like ours that we do need to work together. So one of the things that we have been doing over the last couple of months is reaching out to the one or two counties like ours that seem to be doing a lot better than we are. There is, for example, in Essex, they're the only statistical neighbour that have got a rate of suicide that's significantly better than the national average. And it is really disappointing for us, because we have a lot of developments in train, and we want to prevent as many suicides as we can. We want to prevent all suicides, ideally. I think there is a really important role so you mentioned middle-aged men. One of the areas of kind of growth in understanding is around how, if we need to improve services so that we can make sure that we, as much as possible, that we're not losing people from service when they are essentially masking the fact that they're in crisis. That can be really difficult to do. One of the things that we believe does work in that space, that we are currently working on, is that there are a number of community and voluntary sector organisations that can build communities, particularly of men. So I'm thinking like BroPro in East Lindsey, Men's Sheds, and Andy's Man Club, for example. So supporting organisations like that, we've connected with them, and we have launched for Lincolnshire just last month a suicide prevention network, so that we can try and work with those organisations, where we have funding available, that we can go out and support these organisations to do more of the good work they're already doing, because they're better at connecting to the men than we are, and also where we can to support them to also then bid for external funding, perhaps from, like, the National Lottery, for example, had opportunities for funding last year that the LRSN were successful in securing. So I think it's important that we work with them to support them to grow, because in some of these spaces they're doing a really good job, and we need to support that.
Thank you for allowing me to come back, Chairman. That's very welcome, because from personal perspective, I think that is one of the ways that could stem it. Men, not all men, but a large chunk of men will talk to each other. What they won't do is burden themselves to somebody they don't know and they don't trust. And statutorily, they could have, for example, I know a particular group of people who won't admit they need help because of implications. If they have a firearms licence, they're not a risk to anybody else. But if they say to their GP, I need help, their licence goes, and they could need that for their livelihood. So they will simply stay silent. So that those organisations, I think, are a way to deal with that. One thing I'd say to, shall I say, be mindful of, because I think it's going to be a ever-growing problem, is the number of men who feel very isolated, very alone in the world, who don't have a partner and aren't sort of necessarily close to family or are a long distance from family. I think that problem in the next 2 to 3, 5 years, that's going to explode. And if we don't catch this now, we're going to have a big problem. But things are being done locally. I know in my division, for example, things are being done. And we're trying to hold a food bank that I volunteer at. We're trying to organise a wellbeing day to sort of say, these are all your statutory services, these are all your services, they're there, please use them. You can lead a horse to water, but you can't make it drink. I just hope that when we review this in future, Chairman, that those figures start to come down, because they only seem to be going one way at the moment. And it's, as somebody who knows the impact of suicide both professionally and with family and friends, it's traumatising, and it never sort of, you learn to deal with it, but it doesn't take the issue away, and it's always there and it's always on people's mind. But one final thing, Chairman, for somebody to do that, people say, oh, it's very selfish. For somebody to do that takes a lot of guts, and they must feel so low to actually do that. So it's to try and get away from the stereotype that often comes at, oh, it was selfish. Yes, it was selfish to the people that were there because he's not there and they matter to that person, but that person must have felt they had no other option to do that. It takes a lot of courage, because it's not an easy thing to do. It's not an easy thing to contemplate. But I just hope that in the next 6 months or year that we're in a better state, and that it's not going up. Because I don't have the answer, Chairman. I wish I did, but I hope we're in a better place.
Thank you, Councillor Smith. I think we'll bring you back briefly, if we could have it briefly, though, please. Thank you. I think it was a very good point, but thank you very much. The only thing I would add, Lucy, I think from what Councillor Smith is saying is, in reality, I think one of the breakdowns is that if you go into a crisis-type scenario, you get to see someone on a regular basis within, the health service. The reality is, when you move from crisis and perhaps go into talking therapies, there is quite a long wait there, which is, quite concerning when you're already, potentially have suicidal thoughts. And on the other side of it, I do understand this from LPFT, if you potentially miss a phone call or they don't catch you the first time, they don't chase you. And that's a really worrying statistic. So I think trying to tie that in, although it's, not necessarily our area, it's got to be part of that prevention, I think, as well.
Yeah, absolutely. And we do work closely with, so LPFT's got a suicide prevention and self-harm prevention lead who we work with really closely. And I think there is also another gap in that space, and that this is what I'm kind of meaning when I talk about looking at approaches, kind of new approaches to supporting people who are actively feeling suicidal, or they've made a suicide attempt but aren't perhaps experiencing mental health crisis. At the moment, if somebody makes a suicide attempt and they are conveyed to A&E, then if they stick around long enough, and often that can be a really long time, then they will be reviewed by liaison psychiatry. If they don't want to or don't need to go to A&E, at the moment there's a gap there if they're not in mental health crisis, and that is a key gap that we really do want to fill, and we've been actively looking at what other areas, and a lot of areas don't do anything in this space, but there are some examples of services in place elsewhere, often community and voluntary sector led, which are out there in communities and that can wrap around that individual really quickly to support what's going on for them in their lives at that moment in time, and help them to understand what they can do to manage how they're feeling, and also, if and often it is, are there other services out there that can support them around debt management, for example. So that is a real priority area for us.
Thank you, Lucy. I've got Councillor Parkin next, please.
Sorry. I think some of my comments are very much now with the background of the professional hat on in terms of funeral celebrancy, having worked directly with a number of families who have been in this position. And I think as a committee, we need to express our sympathy and our sorrow to families in Lincolnshire in this position, but also as well convey our thanks to the staff such as Lucy and her team who are working to prevent this, because in fact the emotional toll on the professionals involved can be very, very high. And I think we need to acknowledge that while we recognise there's problems and there's those issues, that we actually have a core team of staff who are taking a real emotional hit themselves in dealing with this situation. Now, I think we need to acknowledge that. I found the audit really, really fascinating because while we must never forget that each one of these deaths is a very much loved individual with loved ones around them and friends around them. In fact, getting down to what the data says is really important in terms of stepping back a little bit and trying to make sense of what's going on. Lucy, with the data on table 12 for the risk factors, I think it's really good to break it down. But what concerns me is that for many individuals, they will have a number of those, and possibly even almost all of them. And so for me, I wondered, now we've got that broken down, is there a way that we could use that to almost identify people in advance, that if they're showing a number of those, is there some intervention that we can almost, do they show up as a red flag suddenly if you're aware of an individual going into any organisation who is showing multiple issues such as that? Secondly, employers, I think, have a potentially really important role here, because sometimes it's actually employees who notice things, and that the masking is done to quite a convincing level to close family. But performance at work, that kind of thing, can start to ebb. And so I was wondering if we could do more in terms of reaching out to employees to make them more aware of what these red flags could be with their employees, but then equip them in terms of what interventions they could make. And I cannot, whether it be a family member or whoever, emphasise the importance of asking that question. Have you ever had those thoughts? Because most of the time, people who are having those thoughts, they are not wanting to act on them. There's a real journey to actually then carrying those thoughts through to the end. And if we can actually acknowledge them, whether it's an individual or a professional basis, identify those people, then we've just got to put a pin in it. We've got to be able to spot these people.
Thank you. And I thank you for the recognition, because it does take a toll on our team, but we make sure we put good support in place for them in doing this work. Just in terms of the data first, one of the challenges we have is a lot of these factors don't emerge until after someone's died, and it's part of that narrative process where people present evidence to the coroners. However, some of them we do know about in advance, and I think there is some merit in us having a think about which of these we might be able to pick up on. The challenge is that it's often the ones that, like the financial concerns, can be quite difficult to know where to capture those, but it's definitely worth us thinking about. And I think that one of the things we are doing is we've started some work to understand within our population health management joint data set. So within that data set, it's not going to capture everybody. However, there is what's called a flag that GPs use if someone has talked to them about suicidal thoughts, suicidal plans, or having made a suicide attempt. And we're just in the process of doing a deep dive into that intelligence to see what else that can tell us about identifying people in advance, and potentially, depending on how that goes, that might create a mechanism through which we could do some work with specific cohorts in our population who we think, based on that intelligence, that data, what they've shared with healthcare professionals, we could identify risk groups and work with them. Obviously, it relies on people having spoken to a health professional and that health professional having recorded it. But it's a starting point for us to help to understand more about people who are still with us, who we can work with, hopefully, to prevent a future suicide attempt. So that's the data. In terms of working with employers, I think that's going to be really important. So we've started with, under that sort of 8th commitment, we've started with some of the big employers, with the local authority, with our NHS colleagues, but we also had a number of other employers who were at our suicide prevention conference because they were interested in learning generally more about what they could do. But it was companies like Anglian Water, for example, who were there in part because of an interest in people who are dying by drowning, where it's a suicide. But also we used that as an opportunity to talk to them about how do you support your own staff? What's your awareness like? Do you have training in place? I think that programme of work around working with employers across the county is going to be really important, because it comes partly back to how we promote those conversations in our communities and workforces and employers. They're a type of community, aren't they? And they're a community where we'll often be able to access middle-aged adults in a way that we can't through certain other community routes. So it's an important avenue, I think, for future work.
Sorry, there was just another organisation I missed out in terms of working with the DWP in people who were going through with benefits claimants, because in fact they could be in a position where they could pick up certain cues and red flags, and do they then know what to do if they are concerned with people?
Yes, the DWP have done a lot of work in this space, and actually we use them as an exemplar for talking to some of our own organisations locally. So they've got a process in place both for supporting individuals and also for supporting the DWP officer, so that they pair up. So they do have a process in place. They came and talked to us probably about 18 months ago, and then made an offer out to different organisations across Lincolnshire to support if they were interested. So they are kind of slightly ahead of us in this space, as you might expect, because a lot of the people that they are supporting are really vulnerable.
Okay, thank you. I've got Councillor Sear next, please.
Thank you, Chair. Last time I visited Indeed group, it was nearly same subject. And that time, my division Maplesoft, that was highest for suicide. And I know they've been doing some like night cafe, things like that, and some local hope, like homeless, hope out, doing that. But other group, it just setting up, it to do with, I don't know, can you this word, like people want to come out. They don't like the lady, like what the word is, like, they have the group there, it's quite serious, and the postman, and he's like man, the word is. Then he said that group, and he said quite very good, they finance themselves. And my question is, I agree with Councillor Smith and Sarah, my question is, how long when the waiting list to see somebody, how you recognize it? Because from I heard from, my residents say, oh, my family have that problem. It's a long time to see somebody diagnosed. By that time, it might be too late. So people could hide in. You don't talk about middle-aged man. You talk about the man, but so women, see well, and the young children. And these days, children being bullied on social media, on a school bus, things like that. How can we feel like, how can we stop that? Because you said you have a big gap to diagnose, but people can hide, say, oh, I'm okay, I don't want to see. But you don't have a man chat and whatever to do. But how to get these people to come to us? You have to do something, not feel like, oh, I walk into this center, oh, I'm mental health, I want to kill myself. We have to do some different kind of marketing to let them feel happy to come in. And that's what I think. And I think it's a gap there. It's a long waiting list. People cannot see the doctor. Sometimes they don't say to the doctor, oh, I'm not dead, but the doctor give you a pill, and that's okay. But something, it have to be sorted out. It's very worrying in rural areas, especially on East Coast. Thank you.
Thank you. Yeah, and I think there's something really important for us around supporting people who, and this strays into broader mental well-being and as well as suicide prevention, because they are inextricably linked. But I think there's something really important about understanding the kinds of support that work best for people in this, who might be in suicidal crisis. And for certain people, it is about specialist mental health support. And for other people, it might be about relationship breakdown. It might be, it's probably a culmination of many different things that sort of pile on top of one another and someone reaches that point of crisis. Often a GP isn't where you'd want to go for that support. The NHS isn't where you'd want to go for that support. You need somebody to talk to, and that person might be a good friend. It might be, and we often find this, we talk about this in the broader mental wellbeing space actually, groups like Knit and Natter for women are really positive for your mental health and well-being, and that we see the same thing in men's sheds. One of the reasons why men's sheds work so well is because they're doing something. You know, you're making a bowl, or you're knitting a jumper, or Bro-Pro, they play a lot of Uno apparently. You're playing a game. You're not there for a heart-to-heart, but whilst you're there, it's an opportunity to have a conversation, and that opportunity to have a conversation lightens the load a little bit, and people might have ideas about what's helped them, or they might know about an organisation that's helped them. And so I think there's a key role for that broader community offer. For some people it is about health services, and waiting lists can be difficult, but I think for a lot of people it isn't. And I think for us in this suicide prevention space, where we can really make a difference, working alongside colleagues from LPFT who are really focusing on the specialist mental health support, is making sure we've got the best offer we can have within our communities, that we can talk about suicidal feelings, and we try and tackle and reduce some of that stigma, because people are still afraid to talk about it. And that's kind of natural, because for years it was a complete taboo. It used to be a crime, still is in about 35 countries. So this is one of the big tasks we've got, I think. But community support, and really understanding those local groups that are driven by local people based on a shared interest can be so valuable in this space.
Okay, thank you. I'm acutely aware of the time, and I've got 7 more speakers, so I am going to close down the list for those that wish to ask questions. So I've got Councillor Pessell next, please.
Thank you, Chairman. Firstly, in regard to the working with those with lived experience, as someone who falls into that category, I would be grateful if the details of how to get in contact with that agent service were provided, not specifically just for myself getting involved, but so we can circulate it to others who may be interested. Just bear with me 1 second, I've lost my... there. Looking at the statistics, we've got fairly good breakdowns of individual criteria. I'm just wondering, would it be possible, either in the statistics you've got or in the statistics going forward, if we could get slightly better breakdowns in terms of specifically people with long-term health conditions and disabilities who I fear may be getting at more risk due to the delays in treatment that's going on in the NHS at present, leading to risks not only to a degradation in mental health, but also suicidal thoughts produced by ongoing mental pain and physical discomfort. As you say, some of the key drivers can be non-mental health related. Also, in terms of categories, there seems very little information in the documents, and I'd be grateful if we could get some more of this going forward in terms of people in marginalised groups such as the travelling community, who have very patchy contact sometimes with the health services and do suffer from many of the indicative red flags mentioned. Also in regards to sort of ethnicity, because again of cultural taboos surrounding mental health. Whilst we in the Western mind sense have been improving our willingness to talk about this, that doesn't extend to all communities and may need a bespoke approach to be taken. What statistics do we have in regard to young people who have some form of gender dysmorphia moving, where that is treated or untreated, tied into possible wider issues with mental health, and could those be collected and shared in future?
Yes, thank you. I'll be in touch directly about how to get in contact, but we do also have a generic email address now which anyone can use to ask questions or get in touch, so I could perhaps share that with Simon to go out with the minutes. In terms of the data, some of that is possible and some of it is difficult. So in terms of long-term conditions and disabilities, it's something that we have a system called real-time suspected suicide surveillance. So we get reports every Monday from the police on people who are suspected to have died by suicide in the previous week. And then we use that to track in real time, because obviously the coroner's data, the ONS data can take a year and a half to come out. So we use that to be more proactive. We've started to see an increase, for example, in people who report chronic pain, dying by suspected suicide. So that is something that we're aware of, and it's something we'll pull out in the next audit, which will be out in the next couple of months. In terms of marginalised groups, it's really difficult because we are talking about very small numbers, and similar for children and young people, because it's one death per year, one death too many, it means it's impossible to split it out. But we do look for trends, and we do also look nationally. So we look at patterns of what's happening nationally. So around the traveller community, for example, we can look at what's happening nationally in that space, and we will learn from other areas. And sometimes we change our practice based on national evidence, because we think it would be good practice to implement locally. And for ethnicity, we do see around about 14% of our suicide deaths are in Eastern European migrants, which is about on par with the proportion they take up in our population. But they do tend to be linked more closely to domestic abuse and domestic homicide. So that's another area that we focus on. So things we can do, and we'll build what we can into the next audit.
Thank you very much.
Thank you. I've got Councillor Allen next, please.
Thank you, Chairman. I'll be quick. It strikes me that your work is, I think, excellent in terms of understanding what is happening. I think the difficulty then is actually translating that into change, or to address the issues, that appear in the statistics. And as a number of councillors mentioned, we do need to seem to address that, because we are out of kilter with the average. I know it's small numbers, but I'm sure we would like to be in a better position than we are. And it strikes me that the difficulty we have then is actually identifying the changes that we can put into place that are actually going to reduce the number of suicides, to the benefit of the statistics and our position in the league tables. Because a lot of it, I think, from looking at the papers, is that a lot of it is suicides by people who aren't necessarily visible, should we say, to people who can actually then say, you need to do this, you need to do that, and you need to do the other. Go and go and join a knitting group, or whatever it is. And the action takes place before those sort of discussions can almost take place. So there is an issue there in trying to actually create a situation where people are nowhere to go to talk to people, and do feel it's beneficial to do it, as opposed to putting a noose around the neck and doing the final thing. But there does seem to be a lot of situations where we must be aware that there are candidates appearing that ought to be contacted as a matter of course, rather than waiting for us for them to contact us or contact groups for us to do it. Anybody that's should we say has got some form of mental health record where there is a flag against their name, you know, it shouldn't really be carrying out a suicide, I wouldn't have thought, really, if it, in the ideal world. And anybody that's had an unsuccessful suicide attempt shouldn't really then be getting into a position where they have a successful second attempt, to be honest. And I hear what you say about, you know, going to hospital and unless they sort of put the hand up and say, I need help, I don't think that's adequate. I think if people in the NHS are aware of the situations, they ought to put the flag up and not wait for the flag to be volunteered. And that might have a significant effect in terms of reducing numbers. And that's really where, you know, we ought to concentrate on to a certain extent, the easy issues first, and then deal with the more difficult issues, which will be quite difficult to deal with.
Thank you. Yes, I agree. I think attempted suicide and supporting people who've made a previous attempt is a kind of critical area for us to focus on. Going back about 3 years, there were two areas where we felt we had big gaps locally. One was around bereavement support. So if you know someone who's died by suicide, you're significantly more likely to go on to take your own life, and that's why the Integrated Care Board commissioned bespoke suicide bereavement service called Amparo, which has been operating for just under 2 years in the county. So suicide bereavement support was one key area. Supporting people who've attempted is another key area that we need to focus on.
Thank you. I've got Councillor Morgan next, please.
Yeah, thank you. I think my fellow councillors have made some very good points. Looking at it really high level, it seems that what we're really talking about is crisis management, when what we really need to be focusing on is prevention and putting in the things in place in the first place to avoid people getting to that stage in life. When we actually look at some of the issues, I think one of the things that really shouts out at me was the importance of human contact, cuts in community services, etc. have had actually a profound effect. The point was made regarding the NHS waiting lists and how is that directly impacting actually overall on suicide rates. It's interesting you've picked this up and are looking at the impacts of chronic pain, because I believe very strongly it's having a big effect, as is poverty. I know a number of people with mental health issues, and the DWP in their mind are a large part of the problem rather than seen as being part of the solution. And it's because they're implementing the cuts that we're seeing in benefits, affecting their overall quality of life, putting more pressure on them, especially if they also suffer from ill health and other issues. I think that there are some other areas as well. If we look, for example, it's interesting, the situation regarding men, because if we actually look, for example, at broken families, and sadly there's too many of those, actually men lose access to the children because the housing system and a shortage of housing actually affects them really badly, because they're only given access to children, enabling them to stay overnight if they've got 50-50 custodial access. Otherwise, they find themselves totally remote and potentially divorced from the whole family, which has a huge impact on their mental health. I think there are some really complex issues here. I'm really interested. We haven't got figures here around the stats looking at what time of day people are to commit or suicidal. I say that because my former experience, I've actually worked as Samaritan. I've also worked in the prison service on night duty, where my job was to keep people alive, and I did that for 5 years. And one of the biggest times of risk is night time, but that's when we've got the lowest and least resource actually available. The other thought strikes me, I've had the pleasure of attending Samaritan's 50 years in Grantham earlier this year. They are totally dependent on public donations, such a crucial organisation for support, available 24/7. But again, even they struggle at night time because they're reliant on volunteers. And we've mentioned stuff, I'd love to give credit to all those volunteers across all our organisations who aren't paid, who are doing an incredible job supporting people out in the community. I'm actually angry. I am angry that we live in one of the wealthiest countries in the world, and yet when you look at quality of life overall, we are falling in the ratings very badly. There is something seriously wrong with our society. One of the requirements I've picked up locally from family is going back to bringing multi-generational households back. Let's have grandchildren with their parents and the grandparents coming together so that you've got that community spirit starting to grow in the home. Our houses aren't big enough to cater for that because for so long we haven't offered that. We need to start thinking differently, I think, and I think the government needs to start taking this seriously and actually invest in its people. Thank you.
Thank you. Yeah, I'll just come back on a few of those points. Time of day is a really interesting one. I actually don't know the answer, but we'll have a look at that because we do get it through on the real-time suspected suicide surveillance. My instinct is it would be evening and overnight, a lot of it. You're right. So there's so much of the work that we need to do around suicide prevention is around mental well-being. And in Lincolnshire, we have signed up as a system to something called the Prevention Concordat for Better Mental Health, which is around promoting and tackling issues around social isolation and loneliness, that connection, understanding the ways that we can build more mentally healthy communities, if you like, because that helps with resilience in points of crisis. And all of that is so important for suicide prevention, because identifying the one individual or the two individuals who are going to potentially make plans and go on to make a suicide attempt or to die by suicide is very, very difficult. But if we have more, if we have stronger, kind of better mentally healthy communities, then that's going to really help us in that space. I'll pause there, I think. Thank you.
Thank you. I've now got Councillor Matthews.
Thank you very much, Chair. I am here, sorry. And thank you for letting me in. I want to commend Lucy for the work that she and her team have done on raising this issue and engaging in some fantastic work. And it's absolutely clear within my patch along the East Coast, specifically Sutton-on-Sea and then linking to Mablethorpe and Skegness, that there has been a step change in community provision through BroPro, Shine, through CLIP, and indeed to a certain extent through the GP thing. So this is a big challenge, as people have laid out very clearly, but I want to commend you and thank you very much, and please continue. One of the issues that bothers me is a constancy of provision. So we've had new initiatives have come forward, but they're not fully understood within the wider community of provision and other networks. And I wonder how we can join up those networks more effectively and to promote them. So that's one issue that I would hope you'll be able to look at. The one that significantly worries me is transitioning between individuals who have contacted and received service provision, whether it's through LPFT or a GP or indeed some other group, but who then have received their, and this seems very cruel, but they're allotted 4 sessions or they're allotted 6 weeks of support, and they are then almost abandoned and told, you know, don't come back for 6 months. That seems very cruel, putting it in that sense, but that's the way it's understood by these people. And I don't know how we can provide advocacy following to steer through that transition where people are stepped down from service because they're deemed sorted out, but they're not. And actually the stepping down from the service causes a further issue in its own right. So advocacy improvement for transitioning. I don't know who is responsible once they drop off a GP's list or they drop off an LPFT list and they're sat there in the community for 6 weeks, they're untrackable. And I think that's an area where we know who they are, someone knows who they are, and we should be able to track and provide some distant support to make sure we know what's happening to them. And the other one I just wanted to say is there's a young man, I'll call him Alex, who decided to die by suicide hanging in a wood. He was a farmer. He lived within a family. He didn't drink. He had no money worries. His father is involved in strong support in this area. And it was a complete and utter shock to everybody, especially because he had been involved in a news event or where they were talking about suicide amongst farmers. And he said, we need the support, we need that support. We won't be able to cover all of the risk factors through our provision, but we should be covering the risk factors where they know it's been declared and they are actively seeking help, and we should better make that help available to them. But I think you're doing a fantastic job, Lucy. Well done. Publicise it more, get the comms out there. Thank you very much.
Thank you, Councillor Matthews. I'll just pick up on the joining up first. I'm glad you mentioned that. So we have just launched, as I mentioned earlier, our Lincolnshire Suicide Prevention Network. This is there for everybody to join if they're interested in any capacity, any kind of professional capacity, as a voluntary sector organisation, as a volunteer working across Lincolnshire. And we're planning to use that as a way to share good practice around suicide prevention. We're planning to host 3 network events through the year to raise awareness around suicide prevention and what people can do to support suicide prevention across our communities, as well as to work with our communities because they have a lot of ideas themselves. So we want to use it as sort of a two-way conversation. Transition points are really interesting. And for me, in a way, I liken this to the work that we do around drug and alcohol use and our recovery service, which is there to wrap around somebody who might have been through specialist treatment and needs that support as they integrate more into communities. And I think that element of kind of recovery, of support to transition back into communities is really important. And I don't want to stray into kind of LPFT territory, but I think there's really important work happening around the Community Mental Health Transformation Programme and the community and voluntary sector work that's being done to build up capacity across those sectors that has an important role to play in this space as well.
Thank you, Lucy. I've got Councillor Wesley now.
Thank you. I'd just like to talk about, where I think our GPs are still falling down, and I don't think they... Yeah, I don't know whether it's because it's lack of time that they've got, lack of facilities, but I can give you 2 very specific examples. So I had a very close friend who committed suicide in 2021. He was only offered a phone appointment when he contacted his GP, and they very clearly didn't ask the right questions, whatever. He was struggling massively, and he went on to commit suicide less than a week after he contacted his GP. Now, I understand at that time we were coming out of COVID and lockdown, and that was very difficult. But I have a very recent example of another friend and a ward member, and they are in a coercive relationship. Very, very difficult situation for them. We live in a very small community, so it's very difficult for people to get out and do things. I finally persuaded her to speak to somebody at the GP's. Again, she was offered an appointment with a nurse. She went. Basically, she was pretty much dismissed. So we wrote to the GP, we wrote to the practice manager, and said that we had severe concerns about this person and their mental health and what might happen. And the practice manager spoke to her, rang her, didn't offer her an appointment with the GP. The person ended up on the phone in tears, saying that they felt that they were unworthy and, not worthwhile, and they were given a web address. and that was it. And I think this is it. I think if it takes a big thing for somebody in that situation to ask for help, and then when they do, that is what they're getting from a GP. You know, they're just walking away and they're just losing it.
I'm really sorry to hear about both of those examples, because as you say, it does take an awful lot to come forward for a conversation about kind of domestic abuse, suicidal feelings, and we want to make sure that people get the right support when they do come forward. We need to do more with GPs. I don't think there's a lot more I can say than that. It is an area where we've reached out to the Integrated Care Board for a conversation, and that we are starting that. But the Suicide Prevention Conference we had, for example, there were 150 delegates, 30 organisations. There were no GPs there, and so it is an area where we really want to take a big step forward. It's getting in the door for the conversation.
Okay, thank you. Councillor Parkin, I've closed down the debate. Was that only something incredibly brief relating to this? Or?
Yeah, it was just really quickly in terms of the work programme, whether we could actually ask somebody from the ICB to look at this from the GP's point of view, and maybe somebody from an LPFT, because I'm really confident in terms of what Lucy said, but I'm just aware that there's so many of the different agencies involved that getting that wider assurance from all of those other organisations might be quite useful. Yeah,
I mean, we've had LPFT cover this subject quite a bit as well, but I think actually in future, if we're to have anything to do with the strategy, I think having LPFT alongside to sort of counterbalance it will be more worthwhile, and we'll certainly pick it up for the work programme moving forward. So thank you. Okay, I've got Councillor Mackinson-Saunders next, please.
Well, suicide really is one of the great conundrums of life, and it's been going on since time immemorial, isn't it? And you are not ever going to solve that problem, so please don't beat yourself up and all the staff, because we need to get the rates down, but it's always going to happen. And I think there's an awful lot of unexplained suicides. I've spoken to a lot of people whose partners have committed suicide, or their children have committed suicide, and they really do not know the reason why. And so as many statistics as you want to bring up will never solve the problem, I'm afraid. I do know a bit about the Lincolnshire Rural Support Network, and I really want to say how good the work that they do is. They have a base up at Louth Cattle Market. I spoke to Canon Robson at great length about it. It is a huge issue in the farming community, which a lot of us represent. And I did ask Alan, and I have actually spoken to a farmer who has used his services as well, you know, why are farmers pretty prone to it? And he said, well, you want to get out there on a tractor or a plough with nobody else around and all the rest of it, and you suddenly become very lonely and start thinking about your debts and all the rest of it. And you know, I think the LRSN do a fantastic job. They've got a 24-hour hotline for it all and all the rest of it. So I can't commend them enough, and I'm really glad that they've got some more funding, because they deserve it. I know that, and I think that's a Lincolnshire-wide service as well. So I think, you know, we flag them up and thank them from the bottom of our heart for all the good work that they do. At the weekend, on Friday, I was on a train going to London, and unfortunately somebody went on the line at Grantham. And it was quite interesting because all the trains were disrupted going into King's Cross. And it was interesting listening to how people were talking about what had happened and what they'd seen at Grantham, and how they felt for the individual, how they felt for the staff. It's all these ripples, isn't it? And I don't think we'll ever get to the bottom of it all. And we can blame housing, we can blame this, that and the other, but there's no easy answer. And thank you for all you do, because I know you do a good job. And if we can get those figures down, but you'll never, never eradicate it.
Thank you very much. Yeah, you're right. So, I mean, we talk about a figure of 135 people being impacted by each suicide, but when it's somebody who's died on the line, or, for example, a pupil in a school that may have hundreds and hundreds of students, it can be much greater than that. And I think it is interesting to hear about how people talk about it, and it helps us then to think about how far we've got to go in terms of reducing stigma as well, because I think that is a real challenge. So thank you.
Thank you. Councillor Welbury.
Thank you, Chairman. I agree with many of the comments that my fellow councillors have made today, and I have to say it is the right support and aftercare, and especially for the family that have to deal with the person that has either committed suicide or has committed suicide. And it is about practical applications. It's great work, the report is wonderfully detailed, but as Councillor Smith said, it's all about practical applications. So to briefly, because we've all spoken quite a lot, I have a practical application for you. I work in the food industry. In this area, there are many factories in the food industry. They employ very low-skilled, low-paid people that are many are deprived, many are in HMOs. We have to undertake an audit. It's a mandatory audit by the British Retail Consortium. And part of that audit is a section called company culture. We have to provide practical solutions to improve the lives of our employees. It is completely confidential. We have to run a survey every year with our employees to how they're feeling, their well-being is at work, how they're doing in general, and then we have to feed that into our company culture. I think it would be a great idea if you got in touch with the British Retail Consortium and asked if you could work with them, because we always struggle with our company culture to actually make it relevant to a vast array of employees. But I think your Suicide Alliance training would be fantastic. It would also reach quite a wide area of the population, and it has to be translated into any language that you employ, of the nationalities that you employ. I know for a fact that the British Retail Consortium, through their many agencies, this is the audit process, they have many agencies and outside bodies that work within the audit sector, so you can choose whichever audit body you want, are always looking for ways to improve their company culture and make it more relevant. And I cannot say, I have to say this is the most relevant thing, that we've talked about in a long time, and it is something in our area that we have to tackle. And this to me is a practical way of tackling it. Thank you.
Thank you very much. I'll get in touch with them. That sounds like a really great suggestion. Thank you.
If you want any info, then just get in touch, yeah.
Okay, thank you. That's all my speakers now, so I've just got a couple of questions myself, Lucy. On page 42, the 7th commitment states we will improve support for people who have attempted suicide alongside their friends and family. Can you please expand on how this service will be offered?
So there's two parts to this. The first is the Recovery College courses, one of which is focused for people who've attempted suicide themselves, and the other for their friends and family. We're piloting the first of those courses starting next month. The other element is around the support that I mentioned in terms of that gap around people who've attempted suicide but who don't, for example, get conveyed to A&E, to think about that wraparound support for them. So we've been scoping that out in terms of developing a potential proposal for introducing a service locally, and that's something that we're working through at the moment with portfolio holders in terms of developing a proposal, and we'll be looking hopefully to seek approval to launch a service next year.
Okay, thank you. And my second question is, with the highest levels of attempted suicide being patients in the first coastal PCN, have they or the ICB taken any additional steps to try and find and offer additional services, or to do an in-depth investigation into the reasons they are the worst affected?
Not to my knowledge.
Okay, thank you. In which case, I'm going to move to the proposal. I'd like to propose that the consultant in public health be thanked for presenting this item to the committee, and the report on suicide prevention in Lincolnshire be noted. Secondly, that the 8 commitments of the Lincolnshire suicide prevention strategy and actions being taken to reduce suicide deaths be supported, and to thank all staff and volunteers working in this area. And thirdly, that members of the committee be encouraged to complete the Zero Suicide Alliance suicide awareness training and in turn encourage others to complete this training. Do I have a seconder for my proposal? Thank you, Councillor Sear. All those in favour, please show. That's supported unanimously. Thank you very much for the presentation, Lucy.
Thank you.
In which case, we'll now move into agenda item 6. It's 6. Reducing inappropriate out-of-area mental health placements. This item was circulated as part of the agenda pack on pages 105 to 111. Lincolnshire Partnership NHS Foundation Trust has asked to bring this matter to the committee's attention, and I'd like to welcome our presenters online, Lincolnshire Partnership Foundation Trust representatives Chris Higgins, Chief Transformation Officer, and Eve Baird, Chief Operating Officer. And I'll hand over to you for about a 10-minute presentation, or we'll take questions at the end. Thank you.
Thank you, Chair. Yeah, Chris Higgins here, Chief Transformation Officer at LPFT. Just say Eve Baird unfortunately has had to dash off. She's got an urgent matter that's come up that she's had to deal with operationally, so I'm afraid you're stuck with me, but it's something that's close to my heart as this subject, and I had a big hand in authoring the paper, so I should be able to answer any questions that come up. The purpose of bringing the report is really to give the committee an early heads up of a brewing problem that we've got around our capacity to be able to cope and deal with and support all the people needing acute inpatient admission. Reason we're bringing it now is that we're aware, and feedback we've received from the committee before is often when we've made changes in the trust, we've come to the committee further down the line when those changes are either implemented or into a pilot phase. And so this is really an opportunity just to make the committee aware of a problem that's emerging that is reasonably significant, that we're going to probably have to do some significant action to address, and just to get you aware so that we can bring back any proposals as we move forward. One of the other things which you'll see is one of the kind of asks in the paper as well is we know that following the process of change and service change, if that's required, can be really quite protracted at times. And because, as we'll describe in the paper as we go through this morning, there's a pressing issue that's affecting patients and our system, and any support in terms of being able to expedite the process of change would be absolutely gratefully received. But it may not come to that, but it was just an early heads up and so you can understand the context we're working in. What the paper does is focus on our inpatient services and sets out where the trust is, where the system is, and the NHS is in terms of its ambition to provide care as close to home as possible, within reason, I suppose, would add on the end of that. There's certain services that it's expected that are provided in a person's home county, and they shouldn't have to travel particular distances or long distance to access them. There are, however, some types of treatment that it's accepted that for highly specialised care, it's appropriate to travel further for that kind of really highly specialist workforce and facilities. And what I've set out on the third page of the report is those different types of services that our patients, our Lincolnshire residents, access, which ones are the responsibility of LPFT to provide, which are provided in region and are commissioned through different routes. So, not to go into the detail, I'm happy to take questions around that. Things like secure care, so high secure services like Rampton, there's only 2 or 3 of those units nationally, and NHS England have retained the commissioning responsibility for those services, and so they work with different providers across the country, agree how many beds are required, in what areas, and they purchase them directly. And then if we've got somebody who meets that need, or we think meets that need, we refer into a regional team, and they get placed where a bed is available, and that means that could be anywhere for us within the East Midlands region. And just to say, we have limited control over that process. It's a direct relationship that NHS England manage with regional collaboratives. So our influence in that space is limited, but obviously we track those patients and we work with them to help support their discharge when the time comes. There are a number of other placements that I've kind of listed at the bottom of that table, which are not necessarily commissioned by NHS England centrally, but are low volume, high complex cases where we've got 1 or 2 patients with quite complex needs, and the volume of activity doesn't indicate a viability to set up a unit in Lincolnshire. And often in those cases, we'd ask patients to travel to somewhere a bit further afield so that we can put enough patients in an area so we can run an effective service. What we have got is a list of services that LPFT is responsible for in Lincolnshire and the ICB, and together we try to make sure we've got enough beds to meet that need. And you'll see from the table, on the whole, we do meet the need. We've arranged different services where we provide it locally and we have sufficient bed capacity. I think just to draw out a couple of areas where we're looking at is, and they're on our kind of pipeline for thinking, is things like female intensive psychiatric intensive care. We know we provide that locally. We've talked to the committee about that before for males, but we don't for females. But as you see, there's only 3 ladies currently needing that type of care, and so it's not really viable to set up a unit locally. And so we refer into other providers that are neighbouring trusts, but something that's on our agenda all the time. Other areas similarly is high dependency rehab. We know we haven't quite got the number of beds available, but as you see, the follow-on paper that's come in next on the agenda is we're trying to find alternative community solutions for rehabilitation that might mean that we don't need just more beds in county. We might be able to help people in an out of hospital way. So we are looking at solutions to try to make sure that we've got all those people in the rehab pathway are able to be supported in a local bed. The area the paper's focusing on particularly is acute mental health placements. This is when people become acutely unwell, they become too unsafe to maintain their safety in their home environment, community environment, and need a hospital admission usually for a shorter length of stay while we assess their needs, stabilise them in treatment, and either refer on to a more longer term inpatient care or back into the community. And what you'll see there is for both males and females, we haven't got enough beds. Well, that's probably not an accurate statement. There are more people being placed into our beds than we can effectively manage, and that's resulting in us having to place people out of area. Because of that, and because it's not a regionally commissioned service or anything, it's all expected to be provided locally. It means some of those patients are travelling really far to access that support. We're sending people down to London, we're sending people up into Darlington and other areas of the country, wherever there's a bed available at the time to keep them safe. So what I would emphasise on that, those placements are good placements. They're good providers, NHS and other providers that provide good quality care. We check that out with the ICB to make sure we're sending them to a safe place, an effective place. But it does mean people are travelling much further than we want to. And the consequences of all this is there's 3 main impacts of what's happening at the moment. That is for patients and the families. Being separated from your loved ones at the point where you're most vulnerable is not great. It's not helpful for the recovery. It's not a great experience for anybody. It's just a poor way to deliver care. You want to be closer to your friends and family at a time when you need them most. And so it's absolutely a commitment from the Trust and the ICB to stop having to do this where we can for those acute patients. The second element of that is that the impact is that there's a national mandate from NHS England in recognition of the impacts this has on patients and families is to stop doing it by the end of this financial year. And at the moment, we don't look like we're going to be able to do that because you can see that the numbers are there and we're going to have to come up with something significant to reduce that down. And the final element, there's a cost element. There's a significant cost attached to placing people in these beds, and we're still working that through in terms of the financial modelling. But somewhere in the region of 1 to 2 million extra money has been spent this year on placing those people out of area, which is Lincolnshire NHS money that's been spent in other counties. And obviously we want the Lincolnshire pound being spent within Lincolnshire. We've done some work around it to understand what's going on, and you'll see some of the graphs in there that on a regional basis, we're certainly not the worst in this area, but certainly not the best. And we've had periods in time where we've had to not send anybody out of area. We've been in a really good place, but over the last couple of years, you see that that's been increasing over time, and certainly in the last few months, we've seen that increase significantly. And we've tried to do some analysis around what we think that might be, and we don't actually think it's more demand for inpatient care. There's not more people becoming earlier, sooner and wanting to be admitted. What we're seeing is a change in the profile of the need of people. So we're seeing people with much more complex needs, multiple problems at the same time. So somebody might have a psychotic illness, they might have personality difficulties, they might have an eating disorder or disordered eating all at the same time, which makes treatment more complicated and taking longer. And we're seeing the evidence of that there's more people, the proportion of people admitted to our inpatient acute wards, there's more people detained than there was previously under the Mental Health Act. So they've been deemed not to be safe to be in the community. So we can see that that's happening, and we need to think about what we can do about that. And there's some work that we're doing with the services to try to improve the offer of care, but we think that's impacting on the length of stay. The second area is really a lack of appropriate accommodation and the packages of support available in the community to enable people to be discharged. So some of our patients got really complex sets of needs, complex behaviours that aren't always palatable to landlords and other housing providers, and the support package we have to put around people to help them to be safe in the communities is sometimes quite significant. And what we've identified is, again, that's delaying some people from leaving hospital who technically we've completed the therapeutic care that we can provide and the treatment we can provide, but we've got no onward placement to effectively move them onto to help them to get out of hospital and free up a bed for somebody else. And so what we're seeing is the combination of that is causing us to have an increased length of stay, and that means fewer people are able to access the service, and hence we're having to send people out of area. We're looking at a number of areas to address that. We're working with the teams around the treatment approaches and making sure that we're doing all the work in the community to reduce the need for admission and try to turn people around to make sure they've got the right appropriate community packages in place, community support in place. But we get into a point where we're thinking we might have to do something a bit more significant. If this trend in changing clinical presentation, this complexity of care is going to continue, then it might mean that we're going to accept a longer length of stay for people, which means we might need a few more beds, but we're not, or certainly a few more acute beds. So we're at this stage where we're trying to work things out and just come into the committee just to kind of give you a bit of a heads up on this. The two areas that we're specifically focusing at the moment is Ashley House. The committee be aware that we previously closed Ashley House to enable us to set up the community rehab and to become a county-wide service, which is the next paper on the agenda. But that means we've got an empty building there that we could look at doing something different with, and we're considering different options that we could use for that. One of which is, could we create some sort of step-down accommodation for those patients that are awaiting discharge, but don't really have an appropriate place to go to? Could we use that building with other partners to provide a space that we could step people down as a stepping point to more onward accommodation and long-term tenancies? So that's something we're working up at the minute. We're pulling together a bit of a proposal and a business case and options appraisal around that, and hoping to have that some sort of decision around the end of, well, a proposal developed with a recommendation probably by November, December time that will enable us to look at mobilising that if it's a viable case. The second one is there is an option to try to look at the way we use our current inpatient services. So what we're seeing is, whilst we've got not enough beds currently to support the people in the acute pathway, because of the success of things like the community rehab team that we're going to speak about and the other community work that's been going on, we're seeing fewer people needing admission for our reablement ward, fewer people need admission for our low dependency rehab ward at Maple Lodge. And so we're finding that those wards have got spare occupancy at times. So as my previous role as Director of Operations, I'm looking at that going, well, I've got beds available in this part and not enough beds in this part. Is there something we can do to reconfigure what we're doing to provide the need and better meet the need of the population of Lincolnshire? Well, I'll caveat that with, we haven't done the work yet. We can see something that might offer a solution there, but obviously if we want to change and reconfigure wards and what's provided where, then we go through appropriate engagement and have appropriate scrutiny on that. I suppose that's where I'm coming in terms of just getting the committee cited on some of these things, that if we want to reduce those people being placed out of area, improve the experience of care, reduce the cost associated with it, then the longer that takes to enact, then the longer those people are going to be placed out of area. So it's just really to frame it in that way. There's still work to do to get there, and of course, as we progress this work and we identify the right solutions to address this problem, we'll come back to the committee with an update. But that's probably as much as I need to say for now. Hopefully that helps explain the situation and things we're trying to do and where we're coming from, but happy to take any questions.
Okay, thank you, Chris, for that. Just a quick one just from your presentation, because I'm somewhat confused. The last few times that we've had conversations, I know that you've been saying that LPFT has aspired to have a local female PQ. So is that now on the back burner, and if so, what's changed with that, please?
Not at all on the back burner. It's one that's regularly discussed in the organisation. It's a really tricky situation, just that we absolutely want to provide female PQ locally and have that equity for males and females. Our issue is that, as you see, we've got 3 patients. It's just unviable to set up set up an inpatient ward for 3 patients. It just wouldn't be financially viable to do so. So we are having conversations with other partners in other counties, whereas if we set something up, would they be able to use our beds, for example, so we could provide for them. We're also looking at, could we do something different with our estate, so we could provide a mixed sex PQ unit, but there's different views and opinions about whether that's the right thing to do clinically. So we are looking at it, but we've just not come up with a solution at the moment that meets the need. And as I say, it's the numbers of people that require that care at the moment don't indicate as it'd be viable to set up and fund a unit locally, but it's certainly not off the table.
Okay, thank you for clarifying that. Councillor Allen, you're first, please.
Thank you, Chairman. There's not a lot to say, really. I think it's a heads-up report, and I think it's very good in terms of what it actually provides us in terms of the heads-up and the thinking that's taking place. The only input as a councillor I've put into it is that out of area provision may have a part to play even in this thinking when numbers are small, or the specialist items that are that are required are not easy to provide within the county. So that shouldn't be a sort of main driver, just to provide provision within the county. But the report and the table within it does quite clearly show that there are some provisions that are taking place outside the county, which arguably ought to be brought in, and that's medium secure and low secure, and addressing somehow or other the acute inpatient disparity that we've got in terms of a number of those. Even though we've got a fair amount of provision in the county, some are still going externally, which could perhaps be brought in into the area for the benefits that would accrue from that. But that does require perhaps changes in the way that the estate is being managed, or additions to the estate. But they are recognised, and I think that's the main issue. The other thing is that this item needs taken into has a bearing on the item that we've just discussed in terms of suicide, mental health and suicides. And of course the next item in terms of the CRT, I think it's called provision, that's consequent to Ashley House, has a bearing as well, because that might help in terms of actually providing some capacity within the estate and to address some of the issues that are identified in the report. So that's quite good as well. And I always particularly support the idea of using Ashley House as a sort of stepping down facility to actually create space within the main provision as a way of getting people ready then to go out into the community and under the auspices of the CRT people or not. So I think that was a very good idea.
Before you answer, Chris, could I just add on to Councillor Allen's first point? It does say that when it comes down to the both medium and low secure units, that this is not within the ICB's power or yours to make a decision. But is there scope for this to become a local decision? And if so, when would you expect it to take place?
So there are ongoing conversations around the way the funding flows for secure services. At the moment, NHS England are not minded to pass that directed to ICBs in local footprints. They're talking about, again, stepping that down to super regional commissioning arrangements rather than national arrangements, so one step down. But it's one of the areas where, certainly as a provider, we would really welcome the funding flowing into ICBs, because that means that if the funding for patients needing those services flowed at least into ICBs, we could choose where we purchase that or provide something ourselves or provide alternatives ourselves. All I would say on that piece is that at the moment it's difficult. I can't put a time frame around that. It is subject to NHS England's decision around how they want to release that money and where they release it to. We are, though, involved as a provider in those conversations with other providers across the region about what's the right number of beds for the East Midlands footprint, and are there alternative models of care that we could provide that might mean that fewer people need to be admitted to those environments. And certainly in Lincolnshire, what we've seen is when we've put in really robust community services, fewer people have actually needed hospital admission, and there is potential around some of the low secure, particularly if we could put in really intensive support services in the community, could fewer people need to be admitted to those environments? All I would say, again, to caveat that, is these are people who've been through the criminal justice system, who've got convictions, one thing or another, often related to their mental health, and so there's a risk balancing decision to make on each of those cases. So hence why NHS England like to keep a control over some of that at the moment.
Okay, thank you. I've got Councillor Smith next, please.
Thank you, Chairman. I, like Councillor Allen, would certainly like to echo the point around Ashley House. I think that's a very good suggestion, and I think I made the point at the time, which was please don't just dispose of the building. So that's very welcome. The only concern, and it is, and again, thank you for the heads up. The report's very good, and it's appreciated. The concern I have is, as you were speaking, Chris, is what I don't want to happen, especially based on the previous paper, which we spent a long time discussing, is we're robbing Peter to pay Paul. So we're taking from one lower level of provision, of in-house provision, to feed up the chain, when actually, as you've already alluded to, the complexities are increasing in terms of presentation around mental health. I do not see that deteriorating, Chairman. If anything, I can only see that going one way, and it's getting more and more complex. Because although these services are there, as we've seen in the last paper, Chairman, too often, even when these individuals are known to services, ultimately they are failing, and they're not, if they need admittance to in-house provision, they're not getting it, and the end result is, tragically, people are taking their life, or there are other instances where they're not known. So I would urge caution around the potential of reducing moderate to lower end levels of in-house provision, because if anything, Chairman, I think what the previous paper shows is, if anything, we may need to look the other way, because whilst the community care can offer a certain level of support, that can never fully replace an admittance level of support where you have staff 24/7, 365 days a year around you when that's needed for that individual. And I wouldn't want to solve one problem, we create a problem lower down the level of need, because all you're then doing is cascading a problem further down the system, which we already know, Chairman, is prevalent. But other than that, very good report, and I look forward to the future reports coming before us to scrutinise.
Just to come back on that briefly, that's really helpful, and I absolutely agree with the comments made. Is that we're absolutely mindful that we don't diminish one part of the service for a today problem and then create a problem for tomorrow somewhere else. So any proposal that we put through will be absolutely stress tested. And just to say, we're not at that point. I think Ashley House is our preferred route. We're actively pursuing that to see if we can make that work. That may resolve the problem we've got with a bit of extra kind of tighten up of processes. It's just, if it doesn't, we might need to look at something more significant, but whatever we put forward would absolutely be watertight, stress tested before we put it before the committee and others. So, but no, absolutely, I'm very minded that we don't create another problem while trying to solve the one today.
Okay, thank you. Councillor Morgan, please.
Thank you very much for your report. First of all, I would like to concur with my colleagues. I totally support using Ashley House. If we can get that back into action and working for the community and providing a safe, secure and appropriate support for people, I think that is definitely the best way to go. This really interestingly ties up with a different issue I've been dealing with locally, and that's homelessness. And one of the issues that we've been having is that we've got people now who are homeless, who are very difficult to house because they're falling into this category. They've gone through the system, they're out back in the community, and in effect, within the community environment, which, and you've touched on it, their needs are complex, They, for example, may not be taking the meds they should be. Nobody's controlling that. It's totally down to them. Their behaviour would definitely be seen as being antisocial to other people, may even be putting other people and themselves at risk in the community. So that those, obviously we've got different stages here, but there is a need within, I think, certainly our community in Grantham and in the district, for some sort of provision, which is like a halfway, where you are providing supervised accommodation by people who are highly qualified and know how to work with and deal with people like this, who otherwise would fail any other tenancies because of the behaviours that they have. I think if there's any way that you could work more closely with the housing and homelessness prevention teams in our district, and I'm sure this might well apply across the county, then that would be, I think, hugely beneficial. And ideally, what we probably need is a number of Ashley houses across the county, actually, because again, Ashley House is great for Grantham, thank you, but I imagine if you live in Louth or Boston, you might have a very different, feel. Again, you're still making people travel, a very long way from where there's need. I am very concerned about our 3 female patients. What we seem to be talking about here really is a patient need versus operational viability and need. And the NHS is about providing and meeting the needs of patients. And I think that we need to come up with a solution. I don't think it's acceptable that the female patients are having to go outside for support. You mentioned the viability of a mixed sex unit, potentially. My only thought around that is it all depends on how it's done. And if there's a way of, in effect, separating the women safely from the men, but having staff that cross over, then that might be the most practical way to go. But I think this shouldn't drag on. I think that needs resolving. And then just picking up another point, I'm very aware from my work in the prison service, very sadly, that actually there are some hidden side effects for example, people taking spice and even using harmless weed from an early age, and it creates psychosis, and I've myself firsthand witnessed the effects this can have on people. It's absolutely horrendous and has life-changing effects. And I can see, concerningly, I think Councillor Smith touched on this, I can see an increase, because unfortunately we are facing an increase of the issues in the community till we knock that on the head as well. Thank you.
Thank you. Just to come back, I mean, all I would say on the female PQ elements, like it's intensive care, is that, as I said before, it's something we're actively looking at. There's only so much resource to go around. I mean, that's the reality of what we're working with. There's only so much money to be able to spend, so many staff to go around, and so we've got to make sure that we can meet the need within the available resources. But it's something that's absolutely, certainly close to my heart, and actively discussed in the organisation around what we can do. All I would, to provide some reassurance that for female PQ, we're working with Nottingham Trust so that we can make sure, and the neighbouring trust, so that we can place people as close to home as possible when they need that kind of care. But obviously, certainly not. It's far from ideal.
Okay, thank you. I've got Councillor Welbury next, please.
Thank you, Chairman. I do have some personal experience. A family member was out of county for nearly 2.5 years. She was in London to start with, at the Priory, then she was moved to Preston. We couldn't bring her home. It was impossible. There was no provision. 6 months to a year it took to actually get the case reviewed to bring her home. In that time, the personal toll on my family was incredibly difficult. There is no, we're talking now 2015, 2016, so no, not that long ago. All the issues that we've discussed today, I've heard all before, and nothing, in my opinion, has changed. When she was out of county, we came back to look at Ashley House to see if she could actually live there, and it was not possible at that time. There would have to be some significant changes to the way that Ashley House was run, in my opinion. In the end, she was offered accommodation back in county at the Jolly Crispin ex-public house, which was a B&B for a severely disturbed young person who has bipolar and is on 117 aftercare. And that to me was totally and utterly unacceptable. And everything that I've heard and read is everything that I've heard and read since 2015. The only thing that I will say, which I think is relevant, is that there is a private NHS kind of tie-up, a charity house on Witham Bank. There was also one in Spalding, which closed, that she has been in many times. It's like respite. You go in for a week. There is medical care there, but it's more to give the person a respite from their everyday living. And that, to me, has been the most helpful situation that she's been in. I think that if Ashley House is going to be looked at, then maybe that kind of partnership should be considered, whereby it is more of a respite kind of operation that has care on hand if need be. But as I say, everything I've heard today, I don't feel that we've moved on since 2015-16. Thank you.
Yeah, thank you. Just a couple of bits there I would to pick up on. One is things have improved. It might not feel like that, and certainly, sorry to hear the experiences of the person you were talking about, and everything that comes behind this paper is absolutely about the fact that this is huge impacts on people and their families when we place people out of area. We know that, and where possible, that's why we're trying to bring people back into county and provide as much as we can that's reasonable locally. What I would say, just as a help in the context, is that in 2016-17 we had about 63 people placed outside of Lincolnshire in acute beds. Absolutely unacceptable position. We've worked hard over the years to bring that down, and did by 2021 get that to 0. But as you see now of the chart in the paper, is that started to creep up again. And we're really struggling to maintain that 0. Hence, we want to take further action. But this is absolutely the top priority one of the top priorities for the organisation and the ICB for around the mental health agenda, is to make sure that we get that back down to 0, and we will. But it is improved from where it was. I say we've got this emerging problem of the last few months, or last couple of years, instead of the last few months, that's exacerbated it. In terms of Ashley House, what I'd say just on that point is what we're proposing is a different model to what it was in the past. This will be a different type of service, and we want to work in collaboration with other housing providers. That's not our expertise as an organisation. We can do the clinical bit, but other people who are good at housing to help support. The Ashley House bit I'm talking about today is really in relation to this particular problem around these patients we've got needing discharge from our acute wards. It sits within a wider agenda. The local authority, we work in collaboration with them, who lead the housing agenda for mental health, learning disabilities and autism. And there's a system-wide group that's together looking at how we can increase the range and options available and geographies available for different types of accommodation for people with mental health needs. We've just recently appointed a housing lead to work with the alliance of partners around that to help us explore different solutions. So I certainly wouldn't want the committee to think that Ashley House is the only solution. We're looking around accommodation for people with mental health. It's just one particular option we're looking at for this particular problem, but certainly sits in a wider sphere of accommodation needs.
Thank you, Chris. As Councillor Welbury's already touched on it somewhat and so have you, with so many patients currently out of county, can you advise what the average amount of time they are out for? Does LPFT remain in contact with them, and what provisions are in place to ensure that families are able to either keep in constant communication or to visit them, please?
Yeah, thank you. So in terms of length of stay for somebody being out of area, it varies. People are usually kind of average length of stay around somebody being in acute admission is around 35 days, but that can vary significantly depending on people's level of need. We make a judgment call with the clinical teams about what's the best interest of the patient. So if a bed becomes available in county, sometimes we step people back down into Lincolnshire and bring them closer to home. Sometimes it's better for somebody to remain where they are. If they've developed a relationship with the care team where they are and they're happy where they are, then we'll let them continue to see out their length of their episode of care in the placement that we've placed them in. So it does vary around, but the average length of stay for an acute admission is around 35 days. In terms of our contact, absolutely, we've got a team of people that are dedicated to this. They make regular contact, involved in the multidisciplinary discussions, the ward rounds that take place, and maintain that contact throughout somebody's care episode. And we've made provision over the last couple of years, recognising the difficulties of families accessing patients. Obviously, they can use remote access and other things, but we do pay for travel costs and other costs to enable families to visit their loved ones when we, in these circumstances, certainly in the acute area where we place people out of area, we should be providing locally. So, yeah, if it's something we should be providing in Lincolnshire, and we're not because of our own capacity, then we would definitely support relatives financially to be able to access their loved ones.
Okay, thank you. Councillor Atkinson-Saunders.
Thank you, and good luck with trying to solve the local problems. But I just want to say it isn't always a local solution, and thank goodness you do send people out of county and a long way. And I have a relative who went a very long way from home, and it was difficult for parents to visit. They had an acute eating disorder, and they, at the worst of it, they weren't even taking water. They went to a locked unit over by the Welsh borders. They were there for months and months and months, and it's a fantastic story because at the end of it all, they were so inspired by the treatment they got, they have now qualified as a mental health nurse. And they're working with young people. And I think that is a terrific success story. There should be a poster girl for the organisation. I shouldn't have said girl, poster person for the organisation, because it's a fantastic story, and well done. And thank you for sending them so far away, because it saved their life.
And thank you for saying that. I think it just emphasises the point that there's some things that we're good at, but there's some services so specialised that there's only a few people nationally that are that good. And there's, you know, if you think about yourself or your loved one, there's certain treatments, if you were going for the best possible care and there's the specialists out there, you would travel to access it. And that's where we've got to make the balance of what's appropriate for us to have the right skills and competencies and provision locally, but what is it actually what types of services, and those highly skilled services, we group the people together nationally or regionally, and people travel for them, and they get better outcomes. And that's the judgment call that NHS England and ICBs and ourselves are trying to make here.
Thank you very much. Councillor Pessol.
Thank you, Chairman. Just in terms of the statistics that were provided, I'm struggling to see much in the way of prediction of future demand or historic figures. We seem to be living very much in the present, when we really need to be looking at long term. So if this comes up in future, I'd be grateful if we could get some statistics in regard to what future workloads look like. One of the things that was noted as being out of area is the provision of inpatient care for autism affected children and adults. This has been an area of particular concern in terms of quality of care, and I'd be interested on your thoughts as to where you think care quality is by the services that are being provided, and whether this is something that we would look at to bring back into area, so that that very important familial contact can be maintained and potentially done in a non-residential setting.
Yes, so great point. So just two things I would say around this is, one is people with a learning disability or those that are autistic, it's not an exclusion criteria from mainstream services. So those individuals are able to access all the services that we provide here in county if their needs allow it. So we would help support people with reasonable adjustments to access our mainstream services. The service in reference there is for particular kind of highly specialist units, people with really profound difficulties. Again, one of these services where there's people with really highly specialist skills that can support those people in a better way. However, absolutely, if there's ways to support those people in a different way, in a less restrictive setting, then we're absolutely committed to do that. And we're constantly reviewing those cases to make sure that we're able to offer the least restrictive care possible, bring people back close to home. And there's active pieces of work that go on around that on an individual case basis to see what package of care we can put in place, how we can support people locally here in Lincolnshire. But there is a difference in terms of those with, I suppose, more high functioning needs that we can support through our services versus some of the cases that would be described in that area, which are people with really quite profound needs or in a specialist unit. But the point still stands is that we would always try to find opportunities to bring them home and provide care in the least restrictive environment.
Okay, thank you. I've got Councillor Burke next, please.
Thanks very much, Chair, and apologies for arriving late earlier. It's one of those days. Chris, really interested. I mean, I'm grateful to my colleague who's mentioned there are some cases that benefit from out of areas placements, and you've answered that. Looking at the statistics of out of placement patients, is there another chart, as it were, that defines where you would actually send some people out of area because that's in their best medical need? I think that'd be an interesting thing to know. Also, in the report you talk about, or other people talk about, eradicating out of placement areas patients by April 2025. How confident are you of meeting that target? And like others, better informed in this room than I on this so far, interested in the Ashley House. And also you mentioned the reconfiguration of other inpatient services to match capacity. If you could comment on those things, please. Thank you.
Yes, thank you. So where we send people, it varies. We track each of these patients, and our bed management team can has a list of where everybody is. It just varies depending on the service type. As one of the councillors has mentioned today, as people can travel really far afield, sometimes into Wales. If there's a specialist unit, can they meet their specific need? But we'd always look for the closest place first, and some things like the bed availability for acute beds it's just where the bed's available on that day. It's 9 o'clock on a Friday night. We haven't got enough beds to admit the person that needs to come in, and we ring round to other providers, starting with closest first to see who's got beds available. Well, we've got a list of beds that they share, but we work around that to try to find where we can send somebody and try to keep that local. But sometimes that ends up being further afield because it's the middle of the night and somebody needs a bed. So in terms of how confident are we on eradicating acute out of area placements by April 2025? Not that confident, if I'm honest. If we can turn around Ashley House and make some other bits before then, maybe. But we're up against it, is what I would say, in terms of hitting that target. And hence is why I'm here today, really, is that we're up against it on that one. Things have gone the wrong way in terms of where we were on this, and we're just trying to do things to turn it around. So hopeful, but I can't confirm that we'll hit that target. And then in terms of the bit, absolutely, I'll update the committee on Ashley House. It's certainly, thinking if that isn't an option, we're going to have to go to a plan B, but we're working up the feasibility around that, and I'm happy to bring that back to committee once we've understood where we are with that and what the model might look like. And in terms of the reconfiguration, it's just what I said to you before in terms of we've got some areas where we've got fewer beds, we've got fewer patients needing beds than we've got beds available. We've got occupancy spare, so we've got some empty beds in some parts of the trust, and then other areas where we've not got enough beds. And so you could look at that in the context of well, okay, then let's reconfigure that and change the way we're using some wards. But lots of work to do, and picking up the point that was made earlier is what we're really mindful not to do is just create a different problem by changing something and then there's not enough of that bed type. So it's a really tricky one that we're balancing out. So what I would say is there are options to reconfigure. We haven't got loads more money and loads more staff, so what we do is probably going to be within the resources we've got available. But we will look at that as options. But certainly we wouldn't be proposing anything unless it was rigorously stress tested. And at this stage, we're just not at that point yet.
Thank you. Councillor Morgan.
Yes, thank you. Yeah, first of all, just going back to my previous points about working with the local authorities more in partnership regarding accommodation to ease people back out into the community. If a local authority did want to do that, how do they engage with you to progress that? And then you mentioned the issue around resourcing. Can you just clarify, is that around accommodation overheads, or is it staffing? And if so, what type of staffing, and what's being done to address that? Thank you.
So in terms of the accommodation work, if people want to contact me, I can make sure we get people in the organisation linked up. I say we've just appointed a housing lead that's a kind of a system level post for mental health that's working across the partnership, but hosted by LPFT, and that we're going to use that role to really drive and link people up, the housing, the district councils, the housing agencies, and try to really pull together what resources are there, and then we can make cases for further development of different types of accommodation and support. So, but if there's any queries, happy to channel them through me, and I can make sure we get the right people linked in. In terms of resources, it's just there's only so much money to go around. There's only so much workforce available in Lincolnshire. We've got so I suppose that's the bottom line, is that there's only so much money to go around. The NHS has not got an infinite supply of cash, so we've got to just make sure we're using our resources effectively. That's not to say we can't get other investment if absolutely necessary, but we need to demonstrate we're using our resources to the best effect. And in terms of workforce, it's an improving picture. But one of the things in mental health, which is, having worked in mental health services for 20 odd years, there didn't used to be a lot of investment in mental health. There were times where there was hardly any, but over the last kind of 10 years or so, we've seen significant investment in community services and alternatives to inpatient care, which has been brilliant. But what that's meant is our workforce has grown, and we've just had to recruit more and more people. So we still have vacancies in teams. We're still working to catch up and recruit to all the people that we know that we need to deliver our services in the way that they're intended. So it's just that if we were to open another inpatient ward tomorrow, trying to find 40 staff that want to work in that environment on top of the services we're already running could potentially destabilise some of our other services as staff move around and we spread the workforce too thin. So there is something about timing in opening up new services to make sure we don't destabilise the services we've already got. But so it might be a not now issue rather than a not at all in terms of developing new inpatient care, but the money would need to be there, and we'd need to be confident the workforce is there to set up a new service safely.
Okay, thank you. I've just got a few questions myself. So when will the recovery action plan be completed? Will this be linked to KPIs? And in turn, would the committee be able to receive this?
Yes, so I'm expecting the recovery action plan to be worked up probably by November, I would say, to get that fully worked up. We are, say, in terms of the business proposal, the business case, the options appraisal around Ashley House is likely to be sometime in November. To have that, be in a position where we've got a clear view on the future of Ashley House and whether that's a viable option, we're probably talking into December time. But again, that will be subject to funding and other things that we'd need to put in place. But probably, if I was to say December, or I could come back December onwards with something that sets out the different actions that we take in. That probably be fine.
Okay, thank you. My next question is: do you expect demand for the acute inpatient mental health services to continue increasing, or will it reach a plateau?
Well, the million-dollar question across lots of different services in mental health. We saw through and beyond COVID, the demand for mental health services in certain areas rising significantly. I think nationally we're all looking at that as to see whether that's going to plateau. In this particular case for the acute services, what I would say is our evidence to date is suggesting it's not more people, it's just more people with more people have got more complex needs. And so to be fair, my own judgment as somebody who worked in the services for this long is that I don't see that those complexities are likely to diminish anytime soon. So we need to be looking at solutions that recognise that people being admitted are people that are going to have really quite complicated, complex needs and going to need quite intensive treatment and might take longer than it previously did to get into the place where they can lead safe and meaningful lives in the community. So I think we're going to have to look at our models of care, and certainly as a piece of work with our medical director, our chief medical officer, is leading a piece of work which we set off at our kind of executive team 2 weeks ago, which is to look at the model of care in the context of, as an organisation level, in the context of this changing profile of need across our services.
Thank you. And with the report referring directly to Ashley House and Grantham as part of a possible solution, how much modernisation would Ashley House need to provide acute mental health services if that was the decision? And would it be able to cater for all Lincolnshire's current and future needs? And would the funding be available to make these changes?
So just first of all, we wouldn't be looking to set it up as an acute unit. We'd be looking to set it up as really a residential unit with clinical support, recognising that the people that we'd be sending there are people that be stepping down from our acute ward. So they'd be spotted and treated in acute ward, step down to Ashley House and then on to longer term accommodation. In theory, if there was the range and type of accommodation available in the community today, we might not need to use Ashley House for that purpose, but there's a recognition that for some people that stepping down might be necessary for a longer term, and obviously depending on the demand on services. In terms of reconfiguring, I'm pretty confident that with minor improvements, the unit could be turned into a residential type unit, accommodation unit. It was previously open as a ward, as we know, and it was previously used not too long ago to support people from a residential home as part of a kind of a support that we played to the wider system. So we've had people in there recently, but there's some works to do on water testing, all those different things, just that we need to get sorted out. But it would be, a matter of a few months to get that up and running. The cash wise to pay for it, that's one to be debated about who's responsible for funding this. But obviously we've got a significant amount of money being spent on out of area placements at the moment that suggests that there might be something there to play with. But I don't, again, that's a commissioning decision with the ICB and others to work out where best to fund this from. But my take is there's money being spent now and there might be a better way to do it in Lincolnshire and probably more cost effectively. So that's the case that we need to work through.
Okay, which I think fits into my next question quite nicely. How would the cost pressure of £1 million this financial year be reduced if services were provided in the county?
So it's really directly related to the number of people that we place out of area. Everybody we place out of area is a significant cost tax in terms of how much those providers charge Lincolnshire ICB for that care and treatment. And so the fewer people we place out of area, the fewer, the lower the cost. So any work that we can do to put actions in place to reduce that down will obviously reduce the number of people placed out and reduce the cost directly. And that's really the case what we're proposing around Ashley House. If we think we've got enough people that would be able to be supported in the type of environment that Ashley House can provide, then if we can demonstrate that, then we can demonstrate that we could reduce the number of people out of area and therefore we could reduce the cost associated with that. But at the moment, that cost is being borne by LPFT and the ICB collectively in terms of managing that in year. What we don't want, obviously, if this continues, is we'll find solutions to manage that this year. But if this continues, then there's going to be an even bigger bill next year that we need to manage between us, which makes it a challenge for next year and how we use our money to invest in other things. So we will be looking for a solution to that, and not least, as I said before, is there's a national mandate and there's families, people and families at the end of this
service. That's the main driver behind it.
Okay, thank you. In which case I'm going to move to the proposal that Chris be thanked and the report be noted. Secondly, that the committee support for a review at pace of inappropriate out-of-county mental health placements be recorded. And thirdly, that the outcomes of the review be shared with the committee. So I have a seconder for my proposal. Councillor Pessold, thank you very much. All those in favour, please show. Thank you. That's supported unanimously. In which case, we'll now move on to agenda item 7, the update on implementation of community rehabilitation services. This item was circulated as part of the agenda pack on pages 113 to 119 and meets a request from the committee for an update on the county-wide community rehabilitation service after this service was made permanent following the closure of Ashley House last year. I'd like to welcome Chris back again, Chief Transformation Officer of LPFT. Chris, have you got Nick Harwood with you? It's not come up on the screen, so.
I have. Hopefully,
okay.
Nick's just going to appear on the screen now. So, and to save my voice a little bit, Nick is going to lead us through this particular item, if that's okay.
Yeah, fine, thank you. It's about 10 minutes, and we'll take questions at the end. Thank you.
Yeah, thanks, Chris, and thank you, Chair, and good afternoon, committee. My name is Nick Harwood. I am the Director of Operations for LPFT's Adult Community Services. And yes, thank you for inviting us back to update on the community rehabilitation team over a year now from full service mobilisation. And we are pleased to report a positive impact with more people accessing the service than ever did the inpatient unit. We're seeing shorter lengths of stay within that team as opposed to the inpatient admission, and some really good reported patient experience. So the paper is available and for the committee, so I'll just pick out some key highlights if that's okay. So just for some context, we commenced a pilot in the kind of west area of the county, Lincoln and Gainsborough initially, and that was funded through NHS England's Community Mental Health Transformation Programme, and that did demonstrate some really good results and success. To enable a full county-wide rollout of that service, we publicly consulted on the repurposing of Ashley House, or the closure of Ashley House, so that we could repurpose that money into that county-wide service, and that was agreed in July 23. And thank you to the committee for support with this at the time. We've detailed in the paper the kind of aims of the service. However, briefly, this is a service that supports individuals with complex and severe mental health issues that need that kind of really in-depth support to maintain their independence as much as is possible for them. And evidence most certainly suggests that providing this support where people live in their own homes brings about enhanced outcomes compared to inpatient settings. So I've detailed as well in there the current staffing situation. So the model as we've developed now has moved to 3 distinct hubs. So a kind of a team now operating out of the south of the county, the east and the west, with a core team of kind of our leaders, managers and senior staff overseeing the entire service. As is sadly often the case, the east of the county saw the most challenges for us in terms of recruitment. However, I'm really pleased to say that now all areas have been recruited to. Them hubs are now all fully operational, with the exception of a handful of posts scattered throughout that service. But a really good news story in terms of being able to recruit to that service. Despite the challenges of recruiting to the east, we did make sure that people didn't miss out from that part of the county. And we did do some mapping of where people have received their care from the community rehab team. We kind of mapped that against the people that were receiving care from Ashley House, and it very much mirrors. So we have been able to meet the need of people throughout the county. Because the difference in terms of Ashley House, we're seeing far more people than Ashley House was ever able to support. We've highlighted patient experience in the paper using the friends and family test that's used within the NHS, and you can see the kind of positive scores that have come from that feedback. And then I've included some of the feedback we've received from individuals in terms of the care that they've received. That could easily be seen as a cherry picking of some really positive comments and ignoring some of any challenges or negative feedback. But just to be really honest, we haven't received any. And that service, since its inception, has received no complaints. which it is also worth mentioning that Ashley House didn't receive any complaints either, but just to demonstrate that patient experience is something we're really obviously very important to us, and that's proving to be quite positive. So just in terms of some of the details and some of the graphs that I've included and some of the data within the paper, what we're sort of demonstrating is that the community team is seeing on average about 5 times as many people as Ashley House was able to admit. So around about 2 admissions a month for Ashley House, but 10 for the community rehab team. And there's some further graphs in there that show that those seen by the team are less likely to be admitted back into hospital. And if they are, that the length of stay in hospital is significantly reduced. I think something that the committee was very keen for us to feedback on following the discussions over a year ago was, would this place any particular extra demand on the remaining open rehab ward, which at the time we had through COVID period, Ashley House hadn't been operational, and Maple Lodge, which is the unit in Boston, had not seen itself at maximum occupancy during that time, and we're pleased to say that has maintained. So those people requiring that kind of open inpatient rehabilitation service are still able to receive that. We thought as well really important to highlight the kind of health inequalities that we spoke about, and very much worth kind of highlighting that this group itself, the people we look after in this service, are generally a marginalised group with severe mental illness. But the service is also very minded to make sure we target all those other health inequalities and that we are providing that service for everyone that needs it. Next step for us really in terms of the service, obviously we know there's some really good work going on, but we do want to commit to a full evaluation of that service over the next year. We've kind of not commenced that piece of work from a more formal perspective, doing lots of evaluation ourselves internally. But as a new service that you know did see a ward close, we kind of want to think about how we really do demonstrate the value that that's brought, but also acknowledging that this was from a national point of view, community rehabilitation teams were a must do. So you know, I guess we've met the national expectation of that, and the impact seems to be really positive. And we'll look towards kind of regional health innovation network to support us with that evaluation over the next coming months. There was another question about the future use of Ashley House, but I think that's been pretty well covered in the previous item, so I won't dwell on that. And that's probably all, Chair, that I need to say at this moment in time. So thank you.
Thank you. That's really helpful. We've got Councillor Smith first.
Thank you, Chairman. You'll be relieved it's very brief. I would just like to ask that after the full service evaluation, that if that could come back to us at some point within the work programme, that would be very welcome, Chairman, so we can fully assess things. Thank you.
Yeah, thanks, Councillor Smith. We'll ensure that happens. Any other? Yeah, Councillor Mackinson-Saunders.
Well, I like the term East Hub, but where is the East Hub and what does it actually do, please?
So in terms of, so we've kind of sort of been grappling over a couple of years really about how we split up the geography of Lincolnshire to ensure that we've got the right coverage of our, you know, makeup of our teams. So across the range of services we have in the community, if they're not big enough to be in a locality, and by a locality we're talking loosely based around the primary care network footprints, so our county-wide services we've split into those 3 areas: east, south, west. So that ensures that each of the locality teams has access to these dedicated focused services. The hub itself, I guess, is a term rather than a location. So they are based within the Louth, Boston and Skegness area. So they cover all of those 3 localities, similarly for the towns in the south and in the west. So I hope that answers the question.
I'm still confused. What services you offer in, say, the Louth area, for instance, because a lot of us aren't aware of them.
Okay, so I was here to talk about the community rehabilitation team, but there's a whole range of services that exist in certainly in the community, from community mental health teams personality and complex trauma team, community rehab team that we're talking about, perinatal mental health services, early intervention in psychosis services. So a large range of services that operate out of all those localities, including Louth.
Thank you. Councillor Morgan.
Yeah, thank you. On page 119 of our report, future demand, you're saying at present there's no indication of unmet mental health rehab needs. How do you actually identify what that need? It sounds like a really basic question, but how do you actually identify need? I'm mindful of our earlier agenda item where basically there were general concerns about accessing mental health services through the different GPs, for example, etc. So how do we know we are actually addressing the needs out there in the population?
Yeah, thank you. A really good question. As I guess a more specialist service for this particular service, the people that engage in it tend to be patients that have been through other parts of our pathway. So they are referred in by GPs, or GPs are not the only route of referral these days into our services, and they're either as during presentation demonstrating that they've got significant issues in terms of being able to care for themselves. This is a group of people that the highest risks generally are around self-neglect. So we'd identify that early on in people's assessments. And I guess there's a couple of elements in terms of how the service operates. One is at that front end, people coming through that have these significant needs, and we can wrap that care around them at that moment in time to support them. Or we've got people who've been through our kind of urgent care pathways into our hospitals, some of those out of area as well in some specialist rehabilitation units, and how we can support those people to come back into their communities, wrap the care around them that they need to be able to meet their needs. But I guess the wider question about future need is something that we continue to monitor. I'm trying to make that point really, that as of now, it seems as though the team has the capacity to manage the referrals and the people that are coming through, but we keep a very close eye on that in case we need to think about additional investment and service enhancement expansion in the future.
Okay, thank you. I don't have any further questions. So I've just got one myself, and that is it possible to give a figure on the percentage of people surveyed who responded to the Making Your Experience Count survey, please?
Is that in terms of how many people responded to that survey?
Yes, that's correct.
Okay. I don't have that figure to hand, but that's something I can certainly present to the committee post the meeting, if that's okay.
Yeah, that'd be absolutely fine. Thank you very much. In which case, as there's no further questions, I'm going to move to the proposal that Lincolnshire Partnership NHS Foundation Trust be congratulated on the implementation of the Community Mental Health Rehabilitation Service based on the reduced lengths of stay and reduced admissions and the positive patient and family feedback, and that we request LPFT to come back to committee when the full service evaluation is completed, if it is deemed necessary for the committee's consideration. Do I have a seconder? Thank you, Councillor Morgan. All those in favour, please show. Thank you. That's carried, and thank you very much for your presentation and attendance today.
Thank you.
We'll now move on to, thank you. We'll now move on to agenda item 8, the work programme. Hand over to Simon to walk you through it. Thank you.
Thank you. Thank you, Chairman. If I could just ask the committee to look at page 122 of the pack. Just on the items listed for November, I just want to say that number 4, pharmaceutical needs assessment, will be on the list, but it's not a full item in the way that a normal item would be, giving full consideration. It will just be effectively asking the committee to establish a working group so that a working group can go through the pharmaceutical needs assessment. Moving to December, I've received notification this morning that the ICB wish to bring an item on the Stamford engagement exercise, which I believe is due to start shortly, although I don't have a date for that. But the ICB wish to bring an item to the December meeting, which, if you can look at page 123, is already quite full. So I'm going to have to think about how we squeeze that in, given that if we could take those, you know, given that we have a sort of a 3-hour time slot, but we might need to finish slightly later, maybe on the 4th of December. That is all I have to add to the work programme. Thank you, Chairman.
Thank you, Simon. Any comments on the work programme? No, thank you. I'll take it that we're all happy, in which case. Yeah, thank you. Okay, in which case that brings the meeting to a close. Thank you all very much for your attendance today. Thank you.
Thank you, Chair. Well done.
Thank you, Colin.